when I started out my nursing career, I worked at Montpelier Rehab as an LPN. Sue was a certified wound and ostomy care nurse there. When you guys become nurses, you guys are going to love to see these ladies or gentlemen, because they actually come in and save the day a lot of times. You have leaking ostomies, you have wounds, and you just don't know what to do. Wounds and decubitus, bed sores, all of those things, it is very much a specialty in its own. You will find that wound and ostomy nurses probably know more than physicians 99% of the time. They have intense CEUs that they have to complete, continuous education that they're constantly doing and keeping themselves up to date with the most recent dressings and things of that sort. So with that being said, I introduce Sue Cole. She is a wealth of knowledge, and enjoy what she has to say.
Okay, to start today's lecture, I want you each to take a handout, an evaluation form, a cupcake, a napkin, and a spoon. And please don't eat the cupcake, it's part of a demonstration. They are edible, okay? After we're done with our demonstration, you're welcome to eat the cupcake, okay? But go ahead and come up and get your handouts, your cupcake, napkin, and spoon, because we will be using those during our talk. A pressure ulcer. A pressure ulcer is any lesion caused by unrelieved pressure resulting in damage to that underlying tissue. A pressure ulcer usually forms on parts of the body over a bony prominence that bears weight when you sit or lie down for long periods of time. And I took that definition from Community Hospitals of Williams County from their policy and procedure. What's the most frequent area of pressure ulcers? Has anyone discussed this yet? No. Nothing? Okay, can you guess where the most frequent? The heel. Some say coccyx, some say heel. Coccyx is the most frequent, okay? But you're not far behind when you say heel, okay? That's the second most. And in the facility that I worked in, heel was the most prominent. But sacral is the most common one. Second most frequent pressure ulcer is the heel. And I worked in a rehab long-term care facility. We had a lot of knee and hip surgeries, and they are very, very high frequency to get those heel injuries. So that was the one that I saw the most, was the heel. All right. Stage 1. In a stage 1, it's described as intact skin that is non-blanchable redness of localized area, usually over a bony prominence, or in dark people, it's a darkly pigmented skin. It may not have any visible blanching. Its coloring may differ from the surrounding area. So, take your cupcake, all right? Test it to see if it is a stage 1 or not. In a stage 1, you don't want any blanching. You don't want it to change colors, okay? It's gonna just stay red. If it's okay skin, it usually would go down and pink back up, okay? Okay? So go ahead and take your spoon and press on your cupcake. Did it stay red? Okay, if it stayed red and wouldn't change colors, yes. Did it stay red?
Thank you.
Okay, it's probably a stage 1 because it didn't pink back up, did it? It just stayed red. That's a stage 1, okay? No blanching. stage 1. So remember that. With your stage 1, it's going to be red and it's going to stay red. It's not going to blanch at all. Let's look at stage 2. Stage 2. What is my typical things about a stage 2? You're usually going to have partial thickness loss of dermis. It's over that bony prominence. It may be a shallow little open crater. It may have a nice little pink wound bed, but there can be no slough. Do you know what slough is? Pardon?
Stringy.
It's tissue.
Tissue.
What? I can't hear you over here.
Like a yellowish.
It's a yellowish, but it's very, very intact. You can't get it off of that wound. Okay? It's usually yellow and you can't scrape it off. It can't be confused with fat. That's what slough is. So on your stage 2, you can't have slough, okay? And it's usually a little tiny dipped out piece of skin. It's that little epidermis. So what I want you to do is create your stage 1. Take your spoon, dip out just a tiny bit of frosting. You have a stage 1? What I want you to remember about this, though, is look at that rest of that definition. Oh, there's an if, and, or but, just like in English. If, and, or but. It can be an intact fluid-filled blister, okay? So that's the exception. Even though it's usually that first loss of that epidermis and that little shallow crater, that little tiny shallow open wound, that first loss of skin, it can be intact skin if it's one of those big fluid-filled blisters, okay? So stage 2 can be intact if it's a fluid-filled blister. Let's go on to stage 3. Stage 3 is full thickness tissue loss. You can have subcutaneous fat. It cannot have bone, tendon, or muscle. It can have some of that that little yellow slough, okay? So what can I have? I can have fat. I can have slough. I'm going to be a little bit deeper in, but I cannot have tendon, muscle, or bone. So go ahead and dig a little bit deeper into your cupcake and get some of that actual cake. Now I've got tissue, don't I? But I don't have tendon, I don't have muscle, I don't have bone, right? No tendon, no muscle, no bone. I can have slough, I can have fat. I'm a little bit deeper in there now, right? That's your stage 3. In this stage, you might start to see a little bit of tunneling. Stage 4. What am I going to get into in stage 4? Well, everything we've left out, right? This is going to be full thickness. You can have exposed bone, you can see muscle, you can see tendon, you can have slough, you can have eschar, and this is where you're going to find that undermining and that tunneling. So I want you to go for the gold. Dig down really deep into your cupcake. Go for the bottom. What'd you get?
It's a real bone.
Did you get bone? You didn't get bone? I got bone. Did anybody else get bone? It's all right, it's edible. It's
Don't
a
tell
ginger
them that,
snap.
I'll eat it.
It's a ginger snap.
Oh.
It's a ginger snap, it's edible, okay? But I wanted you to remember that on stage 4, you can get as deep as bone, okay? Tendon, muscle, bone, all right? You can have the whole thing when you get down to stage 4, all right? Your cupcakes are now edible. We've done this demonstration, okay? Let's go on. You can have an unstageable. Have any of you seen these in facilities that you've worked at? That black, hard eschar that you can't seem to touch? You know, it's just this black, leathery. This is unstageable because you don't know what's underneath there and you don't know how deep that ulcer goes until that black leather is removed or falls off. Then you know how deep your ulcer is. Once that black leather is removed, either surgically, non-surgically, or it falls off, then you know what you're dealing with. But they call it unstageable because we don't know what's underneath that black leather and how deep that goes, right? So they consider this an unstageable. It can be yellow, tan, gray, green, brown. It can be thick and hard. But these are, if you are asked to stage them, they're called unstageable. Now we're going to talk about some risk factors. And we have a couple of assessment tools that we can use to decide how at risk is my patient. The two most common ones that you are going to see in the facilities where you work are the Braden scale and the Norton scale. So I'm going to talk to you about those the most, all right? Now, Barbara Braden came up with the Braden scale, and she assessed sensory, skin moisture, physical activity, mobility, nutritional intake, friction, and shear. And she assigned numbers to these. I think it's 1 to 4 in each category, and then you total those numbers up, and is it the higher the score?
No. The lower the score, the higher risk you are.
The lower the score, the higher the risk you are. The lower the score, the higher the risk you are. Thank you. I'm like, oh, I don't remember now which way it goes. Thank you. And then you can care plan accordingly as to whether they are a high risk for a pressure ulcer, because you add up these 1 through 4s and decide how at risk are they. Some have looked at the Braden risk scale and tried to decide, should we take the total score or should we look at each individual category and just care plan on that? Instead of looking at the total score and saying, wow, they are at risk for pressure ulcer, should we look at sensory perception, and since that scored high, or the other scored, or physical activity scored low, we just need to care plan sensory perception. So they're looking at each individual category rather than one total score. They're looking at subcategories. And when I went to my wound care conventions, that has been discussed for probably the last 5 years, whether we want to look at subcategories rather than just a total score. Or below is considered at risk. There, if I would have just finished my slide, I would have known, wouldn't I? Norton, again, it's basically the same thing. They took physical condition, mental condition, activity, mobility, and incontinence, and they scored it below 9 is a very high risk, 10 to 13 is a high risk, 14 to 17 is a medium risk, 18 is a low risk. And one of our facilities that we send students to does use the Norton risk assessment, so I did want you to be available. That again, there's more than one risk assessment out there. Probably the Braden is the most widely used, but some people do use other risk assessment tools to care plan. These are fabulous to use to get your ideas for care plans, because if being a new nurse, you're trying to look at your patient and you're just beating your head against a wall saying, I'm not sure what I should care plan my patient for. I just don't know what all his deficits are. Go look at his Norton risk assessment or his Braden risk assessment and use those subcategories and say, did he score low in this subcategory? Maybe I need to care plan that. Maybe he didn't have a real low Braden risk, but he did trigger for nutrition. Then care plan nutrition. So that's a good place to go look for some ideas for care planning when you're out there trying to beat your head against the wall for, I'm not sure what I should care plan today. Prevention, that's the key, prevention. Okay, bed-bound individuals, we want to reposition them every 2 hours. We want to offload those bony prominences with pillows or at least a 4-inch foam. Anything less is not offloading. Use devices that totally relieve heel pressure. Avoid positioning directly on that trochanter. Elevate the head of the bed as little and as short of time as possible. And I'll go over that a little bit more in my next slide. Use lift devices to move rather than drag. And we do go over that in the nursing lab with those maxi slide sheets. Use pressure reducing mattresses or cushions. Do not use donuts any way, any type. This is many of the different pressure guideline, what do I want to say, AHCPR, UPC, all of them have said we cannot use donuts. And an example is, I did have a patient that I treated that had a pressure ulcer the exact shape of a donut. Because all it really does is cuts off the circulation to that inner area. It just creates a new pressure ulcer. So you don't want to use a donut. You can use a horseshoe, but you can't use a donut. Okay, I wanted to show you this slide because it addresses that keeping that head of that bed elevated. When you have that head of that bed elevated, they are at high risk of sliding down. And when you slide down in that bed, you create a new shear friction injury. So what we have to do is we have to prevent them from sliding down by positioning them with maybe, sometimes there's actually made a foot pillow so that their feet can't go down to the edge of the bed. But you want to prevent them from doing that slide. And what I wanted you to see here is in the layers of the skin, I want you to note these little things. Note how they look like little fingers. These are the rete ridges. They're called RETE ridges. And they're between the epidermis and the dermis, and they're called rete ridges. RETE ridges. You don't really have to know that for your, but I just want to explain why we get a shear friction injury, okay? What happens is we have those little rete ridges, and when we shear friction, we pull that epidermis and dermis apart by shear frictioning those little rete ridges apart. We just went this way. The shear frictioned them apart. And then we have a new injury because we shear frictioned those apart because they can't hold on anymore. Right? And we can do the same thing with tape burns by stretching that skin to, if we pull our skin like this, by stretching the tape, you can do the same thing. You can create a tape burn because you stretch those rete ridges apart. So I wanted you to see these little rete ridges here between the dermis and the epidermis, holding that together. And that's how you create a shear friction. So you want to put that pillow between the feet and the edge of that bed if you've got them elevated. Like your person that is on a feeding pump, you have to keep them elevated at 30 degrees. They're high risk of that shear friction injury. So there's your care plan. Make sure that you're care planning that they're not going to slide down in their bed and get a shear friction injury. What about your chair-bound people? Reposition them at least Q1 hour. Have patient shift weight, Q15 minutes, if they are a patient that can do their own weight shift, okay? Use pressure-reducing devices for seating surfaces. Again, no donuts. Consider postural alignment, distribution of that weight, balance and stability, pressure relief when positioning individuals in chairs or wheelchairs. Always write up a good care plan so that the people following you also know how to position that person. What is the best way? What you are using? You know, what cushions you are using? You know, left arm up on platform, one pillow. Make sure that there's good directions of how to follow through to prevent that injury. Skincare prevention. Inspect that skin at least daily. Avoid hot water. Use a mild cleansing agent. Use moisturizers for dry skin. Avoid massaging over bony prominences. Cleanse the skin at time of soiling. Minimize skin exposure to moisture. Assess and treat incontinence when incontinence cannot be controlled. Use underpads or briefs that are absorbent and present a quick drying surface. Now, I put in here that with our elderly, they are at a lot higher risk because they have a lot of changes. And so your first population that you're going to deal with is the elderly. So I want you to see some of their risk factors. They have reduced cohesion between that epidermis and dermis, that rete ridges. They have reduced cohesion. It's not, they don't glue together well. So they are at a increased risk of those skin tears. They have a loss of subcutaneous tissue, which leads to increased risk for shear pressure. Just talking to a doctor friend of mine a couple weekends ago, she was complaining that her feet get so tired all the time now, and she admitted it's because she's lost that subcutaneous fat padding in her feet because she's getting older. As we age, we lose that subcutaneous fat, and that's why we get all these wrinkles. As we age, we lose that subcutaneous fat. Diminished sensory receptors. Our older people are less likely to recognize that ischemic pain. We have reduced blood flow to our skin, so we are at increased risk for pressure injury, and we have decreased healing or prolonged healing time. It takes us longer to heal than when we were younger. Prolonged epidermal turnover time. We have reduced activities, and we have less sebaceous sweat glands. That means that our skin is a lot drier. We have to replace that moisture. So our elderly, because many times they're having problems with incontinence and things like that, they think they smell, so they want to take 5 baths a day, which dries their skin even more, and they have less oil being secreted from their sebaceous glands. Their skin is dry, 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 dry. So we need to teach them, take fewer baths, use a pH balanced soap, and put some oil back in your skin. I wanted you to see that we need to watch that they're using a good pH balanced soap that is compatible with their skin. So here's a little pH balance of soaps. The most common pH balanced soap for your skin is Dove. Again, we have to look at their nutrition. Watch for dehydration. They may need a dietary consult, protein supplements, and snacks. Dehydration is common in your elderly because as we age, our urinary patterns change, and although we don't increase our amount that we have to urinate, we can't hold it as long as we used to. And so our elderly want to compensate and decrease their fluid intake, which is bad, 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 because what they don't realize is increased urinary concentration irritates the bladder wall and makes them think they have to pee. And so, again, they're irritated that they feel like they have to pee all the time, so they drink less again, which makes increased urine concentration, which irritates the bladder wall. So it's a vicious circle. We have to teach our elderly, don't try to deprive yourself of fluid. You need to have that water. You need to dilute urine so it doesn't irritate that bladder wall. Water, not caffeine intake. Caffeine is going to irritate that bladder wall. Okay, replacement mattresses. Let's look at some of our different types. We can have static or dynamic. What is the difference between static and dynamic? Static is going to be that it doesn't do anything. It just stays right there, okay? It doesn't change. Static just stays right there. Dynamic is motion. Does that make sense? As simple as I can say. Static, designed to provide support that remains constant, does not cycle. Examples would be foam, water, gel, air, or combination. Overlays, that may be static or dynamic. It may be foam, thick foam thick foam slabs with textured surfaces. They should be 3 to 4 inches thick. If the patient has foam that is only 2 inches thick, it is only supplying comfort, no pressure reduction. Water, you can have a vinyl overlay filled with water to create a flotation effect. Gel, a viscous fluid that conforms to the contour of the body. This allows greater immersion into the surface. Microflow also flows with the patient, movement reducing effects of shearing. You can have an air inflated with a blower to provide pressure reduction. Dynamic is a device powered with a pump that inflates the mattress cells in an alternating cycle. It's an alternation of an air-filled overlay or a low air loss overlay, and I'll show you some pictures of some of these. Then you get into some specialty beds, that air fluidized bed, beds with pressure-reducing surfaces that use a high rate of air blown to fluidize fine particles like little glass beads, little sand beads that float the patient on this surface. Low air loss beds, it's a series of interconnected woven fabric pillows or sections that allow some air to escape through the support surface. The pillows or sections can be inflated or deflated to adjust the level or the pressure of relief. Then you get kinetic therapy. These are beds that are designed to provide continuous passive motion or an oscillation therapy, which is believed to enhance removal of respiratory secretions. They may be available with a low air loss surface or with a firm, slightly padded surface. Now, I don't know if you're familiar with what a kinetic therapy is, but that's where they're kind of going like this all the time. Does that make sense? So not only is it reducing pressure on their body, but it's also helping clear respiratory secretions. That's the kinetic, okay? I really don't see those except in like the large hospitals in Toledo, U of M, those types of places. But I did want to make you aware of those. Okay. I did have the privilege while I worked at Community Hospital of Williams County to do a pressure ulcer prevention program. They were getting ready to purchase some new mattresses, and we as the wound care committee asked if we could do some mattress trials to see if when they purchased new mattresses, if we could bring in a better mattress than what they were currently purchasing. They gave us permission to do those trials. We brought in about 6 different mattresses and trialed them at 3 different hospitals, which was what CHWC had. We had one at Archibald, Montpelier, and Bryan. We trialed them at the 3 different hospitals, came back with some figures, came back with some ideas, and we'll talk about what we had. Our goals were that we wanted cost containment, pressure reduction, and comfort for the patient. This trial was done in 2004. That's just our letter. What we came back with was that we were going to recommend the Maxi Float replacement mattress by BG North. Each mattress replacement would cost $250. Currently, CHWC was using a Medline mattress that was costing them $250 to $300. So we were within the same price range of what they were already purchasing. Maxi Float did have built-in pressure reduction. The current one that they were using had 0 pressure reduction. So you can see that our Maxi Float had pressure reduction at the heel. And just to point out to them, one of their doctors in rehab, because the current mattress had no pressure reduction, was ordering a overlay and a pump for every patient who entered his facility, which was costing an additional $34, or for that 1 year, $5,304. So we could save money on the overlays alone for that physician and for those patients, because we would have a built-in pressure reduction. Here's a picture of the pressure reduction mattress that we liked. And you can see there was reduction at the scapula, at the coccyx, at the trochanter, at the heel. And we were well within budget, almost below budget. Besides wanting to purchase the replacement mattresses, and we weren't saying go all hog and buy all new mattresses for the entire hospital. What we were proposing is you're looking at buying 30 new mattresses. When you switch mattresses, what we would like you to consider is buy these 30 new mattresses and consider BG North for your replacement mattresses. And then as you continue to buy new mattresses, continue to get the BG North until the entire hospital is all low air loss or pressure reduction mattresses. So we weren't saying, you know, switch out the entire hospital right now with these mattresses, but gradually switch over so that the entire hospital will have pressure reduction mattresses eventually. So, you know, it would be a gradual change, but we would like to see in the future that you have all pressure reduction mattresses. We also proposed to them a study that we did that we were doing a lot of bed rentals for low air loss beds. And so we pulled out a couple of studies that there was a couple of patients. One was an average 29-day stay in rehab that cost $3,045. There was another one that was a 47-day stay that was $4,935. And these were low air loss beds that rented at $105 a day, okay? Now, that was just in rehab. Now, you have to understand, rehab is just one little part of CHWC. There's long-term care, there's pediatrics, there's med-surg, there's ICU. So all we pulled out was 2 patients from one part of CHWC. So there's a lot more potential for a lot more rentals than just rehab. What we suggested is this same company offers a purchase of a low air loss bed. We would like you to look at the cost savings of a purchase of a low air loss bed. The purchase of one pressure relief mattress with the capability of putting a pump on it would cost $1,200. Look at that cost saving. One mattress, $1,200, compared to one stay for $4,935. So we identified the high-risk areas as ICU, orthopedics, the LTC swing bed, and rehabilitation. We took it to the product committee. This is a picture of the low air loss bed. You can see those little air cells in there. These are little alternating air cells. So once you put a pump on it, which I'll show you the pump in a minute, it will pump these alternating up and down and up and down and up and down. And it will be a low air loss bed once you connect it to an electric pump. This is what we proposed to our committee. They agreed to allow us to exchange and purchase those new air mattresses. They allowed us to purchase 2 of the low air loss beds, which we did. Now, since I've left, they purchased an additional 3. We have 5. I don't know if they have more than that now or not, but I know that when I left, we were closer to 5. So they were working on getting more and more of those air loss in. This is just a quick, I'll run over it really fast, but the International Pressure Ulcers offers a prevalence study that you can do every 2 years. I participated in it 2 different years. I'm only showing you the part from long-term care and rehab because that's the facility that I worked in. We identified 14 patients the year I did it. There were 2 in long-term care. 1 was an acquired. You really do not want any acquired. It's not good to get a facility-acquired pressure ulcer. You prefer to have 0 facility-acquired, FYI. This shows you where they were located, and as I told you before, our highest risk is the heel, and as you will notice, it was on the heel. This shows you the staging. 2 were stage 2, 2 were unstageable. So you're wondering about that. 1 was in rehab, okay? 1 was that eschar that you can't stage. There were 3 present on admission. 1 facility acquired. There was 1 on an air fluidized bed, and 3 were on the air surface housing overlays. All right, this is the end of the lecture. What I want to show you here is, gotta put it in my pocket, I did. May I demonstrate on you? You are the patient's first line of defense. You are the one that has to do that assessment to know whether that patient is at risk of getting a pressure ulcer. So as my parting gift to you, you are all to come up and take a mirror. I want you to carry this with you just like you would your stethoscope, your pen light, any of your assessment equipment. This will save you standing on your head to assess that patient's wound. You can just float it underneath their pressure points. I can look at her elbow and assess whether she has a reddened area. I can push on it to see whether it blanches. If she's laying in bed, I can check her scapula. I can check her occiput on the back of her head. I can check her heel without having to stand on my head. In fact, I've used it for dressing changes on the heel. I'll put this on the bed, and then I have one hand free to hold the heel up and the other one to do the dressing change. They're wonderful to have. So as my parting gift to you, I would like you to please take a mirror when you leave today, and you can use this for your assessments of your pressure ulcers. With that, I'm ending my presentation. Thank you for coming today.